Good evening, everybody. Today, what we are going to see is how to assess intraoperatively the severity of the mitral regurgitation. It's a trans-esophageal echocardiographic assessment. The mitral regurgitation results from the incomplete closure of the mitral reflex during LV systole. That means there is a backflow of the blood into the left atrium. The intraoperative grading of mitral regurgitation and the assessment of the LV size and function are very important for a timely surgical intervention. The normal mitral valve function involves the structural integrity of the mitral reflex, the subvalvular apparatus, namely the chordae tendineae and the papillary muscle, and the mitral annulus and the left ventricle. So if you look at the mitral leaflet, it's having an anterior and posterior leaflet, two leaflets. The anterior is large and occupy the less circumference than the PML. And each leaflet having divided into three calipes, P1, P2, P3, and A1, A2, A3. And there are two commissures, anterolateral and posteromedial. And this is one of the important pictures we should always know. When we do a echographic windows views, where we are exactly cutting across. So these are the four important views, that is mid-esophageal four-chamber, mitral commissural, and two-chamber, and the mitral, the mid-esophageal long axis. In addition to that, we have a transgastric view. So in a five-chamber, that is slightly aorta is open. You have a A1 and P1. And in a four-chamber, most of the time it is A2 and P2. Then commissural view, that is the 60 degree, you will get a P1, P3, and in the middle A2. Then the two chamber, that is 90 degree, you have an A2, A3 and P3. Then in a long axis, you are cutting across exactly A2 and P2. And in a transgastric view, you can see both the leaflets, all the scallops, and both the commissures. So if you look at the etiology, you can classify into type 1, 2, 3. Type 1 is normal leaflet motion. That is because it may be an annular dilatation or a perforation of the leaflets. The type 2, excessive leaflet motion. There may be a prolapse when till the tip of the leaflets lying below the annular plane, and there is a flail where the tip lies in the left atrium. And type 3, there is a restricted leaflet motion. It can be restricted during the only diastole or both during systole and diastole. So if you look at the sum of the etiology, type 1 may be due to the dilated cardiomyopathy or endocarditis. Type 2 involves degenerative valvular disease, most common, and the ischemic cardiomyopathy. Type 3A, most of the time, mostly common causes rheumatic heart disease. And the type 3B is ischemic or dilated cardiomyopathy. So type 1, as we talked about that, there is a annular dilatation and correspondingly central jet. Then you are having a cleft between P2 and P3, and then you are having a perforated P2. So these are some of the causes for type 1 disease. Type 2, you have a restricted during the diastole. Sorry, you have a flail P2, and then correspondingly the anteriorly directed jet, and then you have a 3D picture showing the flail P3. Then this picture shows that you have a A2 prolapse with a correspondingly posteriorly directed eccentric MR jet. In type 3, it's type 3B, where you are having a PML restricted with a eccentric jet, the restriction during diastole, and type 3A, where the restriction is during systole and diastole with a corresponding central MR jet. So by define the leaflet motion, according to the Carpentier classification, we divide into 4 types. So the type 1, if it is a normal, there is abnormal leaflet morphology, then it is a primary MR. Then if you have a normal leaflet, it can be a secondary or functional. Then type 2, 3, abnormal leaflet morphology by definition, again it is coming under primary. Then if it is a normal leaflet morphology, it is going for a secondary MR. And if you have a more than one pathology, we can call it as a mixed etiology. Now coming to the assessment of the MR severity, what we are looking at is what is the basic mechanism and how severe the MR and what's the LV function and the size and whether the valve is suitable for repair or replacement. So you can divide into qualitative methods, semi-quantitative and quantitative. So some of the 2D images are collaborative, like LV dilatation, the eccentric hypertrophy, without LV dysfunction. And due to the increase in the left atrial pressures, you may have a LA dilatation and then associated pulmonary hypertension. So the first thing is we are using a color Doppler to know a jet area. Even though it is commonly used method to grade MR severity, especially in the preoperative period, it's not very accurate because it depends on a lot of technical details and the affected by the loading conditions under anesthesia. So usually it is not recommended. So you can have a central jet where you can fairly take the area, measure the area, and more than that you can see what is the percentage of left atrial area percentage compared to the jet area. And if it is an eccentric jet, especially like this kind of wall-working jet, it's usually underestimated by almost 60%, so the jet area cannot be accurately calculated. Then comes the continuous wave, Doppler signal intensity and morphology. If it is both, you look at the intensity, whether it is dense or not, and then you are looking at the morphology, whether it's a uniform density or not. So if you have a uniform dense envelope-shaped color Doppler signal, mostly it indicates a severe MR. Then comes the Vena Contractor. So this is the narrowest part of the MR jet. So it represents the regurgitant orifice. It's having the best predictive value in primary MR. You assume that it is a circular orifice, and it is very less useful in eccentric jet and multiple jet. So you should be able to see all the 3 components, that is below the valve and above the convergence and the jet width, full width, and you measure the narrowest part distal to the valve orifice. Then transmitral inflow, whenever there is an increased flow across the mitral orifice, you have the E-wave velocity is very high. When it is more than 120 centimeter per second, it's indicative of severe MR. If you have an atrial dominant transmitral inflow pattern, it excludes the severe MR. Then when the mitral valve is competent, usually you have the VTI is less than the aortic valve VTI. But when there is a severe MR, when the flow across the mitral valve increases and there is increasing the VTI across the mitral valve, the ratio may change, and the ratio of more than 1.4 indicative of severe MR. Then the Next important evidence is the pulmonary venous flow. Whenever there is an increase in MR, there is a decrease in the systolic component of the pulmonary venous flow. So the slowly blunting of the systolic wave happens, and when the MR is very severe, you can have a systolic flow reversal. But we have to be very careful that it is not a single eccentrically directed jet streaming into the one single pulmonary vein and causing the systolic flow reversal. So it is always better to measure in multiple pulmonary veins whenever it is feasible. And we should number some of the causes other than your severe MR to cause the systolic blunting or reversal. So this is the normal systolic and diastolic flow, where the systolic is more than the diastolic wave pattern. And this side, it is showing the systolic flow reversal. And the next important quantitative assessment is the effective regurgitant orifice area, the regurgitant volume, and the regurgitant fraction. So the EROA is a reliable quantitative measure, and most of the time we are using the proximal isovelocity surface area. That means when there is a flow conversion across the valve, you have a lot of isovelocity hemispheres, and then it goes and widen it. So when you look at the EROA, the formula is do by r square by aliasing velocity divided by the maximum velocity. So if you look at that, when you have adjusted the aliasing velocity, then correspondingly, when it is changing the color, you have the hemisphere, and from the blue, it is going to the red. That means the aliasing velocity and this color matches. This distance indicates your pisa radius. And then you have a MR jet V max, and when you put in the formula, that is 2 pi r square pisa, and velocity aliasing divided by velocity, that is peak MR jet. That gives you the effective regurgitant orifice area. So this is how you look at the MR V max, and this is showing, if you look at the radius, that is the yellow is the aliasing velocity here. So from the blue to when the color changes the yellow, this distance shows your radius. So now put it all together, the grading of the severe of the primary MR based on the qualitative and semi-quantitative and quantitative. So when it is severe, you can have a fly leaflet, a ruptured papillary muscles, very large central jet or eccentric jet like a Volga King jet. Then the flow convergence zone, that is very large. That means even without reducing the Nyquist limit, you are able to see the flow convergence. Then comes the semi-quantitative, that is your vena contractor width is more than 7, and you have a systolic flow reversal in the pulmonary venous flow, and there is an E wave dominant, and the ratio is more than 1.4. Then quantitatively, your regurgitant orifice area is more than 40, and regurgitant volume is more than 60. So these parameters says that there is a significant or severe mitral regurgitation. Now, few slides about the ischemic MR. We know that ischemic MR poses a clinical challenge in terms of diagnosis and treatment. The intraoperative decision making is more challenging because of some of the effects of the general anesthesia, which reduces the severity. So it's important to appreciate its pathophysiology and make the correct intraoperative assessment. So basically there is a huge imbalance between the tethering and the closing forces of the left ventricle, which is altered in the ischemic dilated cardiomyopathy or ischemic changes. That is why there is an incompetence of the mitral valve. So you can have PML restricted, that is most common lesion is the posterior papillary muscle ischemia. So you can have a typical eccentrically directed posterior jet. So that is the most common lesion what we come across in an ischemic MR. But you can have a bilateral tethering which causes the central jet. So you have a dilated annulus, you have a tethering. So important parameters to look into to assess the severity as well as whether the valve is suitable for repair or replacement is, one is your tenting area and the coaptation, the tenting distance. So whenever it is more than 2 centimeters square or more than 1 centimeter that area, it is better to replace it rather than repair it. So the intraoperative assessment of mitral regurgitation is a very important one. And whenever we are assessing the intraoperative MR, we have to think about the technical details or the loading conditions which will alter the severity so that the correct assessment can be done and the proper surgical decision can be taken. Thank you very much.